Okay, everyone ready to go? Yeah. All right, so the topic, as you know, for this session is understanding your child's EEG. What I'm going to show you, it has a lot of technical things, but you don't have to. I just want to give you a flavor of what we do with it and what kind of information we can get from it. And it's equally important to know what we cannot get from it, right? So, we will start by telling you, and you probably have some recollection, oops, sorry about that, of your baby being in a situation with the electrodes being put and the number of tracings being obtained in the hospital setting, more than likely. Okay. So the basic components of the EEG, when we talk about EEGs, we often use words like, oh, you know, I see some activity in the electrode T3 or T4 or T5. It sounds kind of mysterious, right? So that part is fairly easy to understand. The way we number them, right, is everything on the right side of the head has an even number. Okay? Everything on the left side has an odd number. Then, the letters we use are amazingly simple-minded. We say F if it is frontal lobe. We say O if it is occipital lobe in the back of your head. We say it's a temporal lobe. Then we say T. So what you see here in this illustration, I'm sorry the projection is not bigger, but let me walk you through some. See, it says here FP1. That's left side of the head. FP stands for frontal polar. Right? It's the frontal pole. If you look here, it says F3, C3 meaning central, P3 is parietal, O1, over here is T3, mid-temporal, T5 is what we call posterior, back of the temporal lobe. It's very hard to read the letters on that dark color, but they're very similar. See, just like C3 here, it says C4. T3 here, it says T4. So it's that simple, right? When somebody starts describing it to you, if they say they saw something on FP1 or FP2, you know they saw something way in the front. If they said 1, it's in the left. If they said 2, it's on the right. Okay? And if they saw spikes in T6, you immediately know, well, that's something in the temporal lobe. 6 meaning right side, because it's an even number. Okay? So that's usually how things are named. And you can see here, F is frontal, P is temporal, central, parietal, occipital, and then midlines are usually labeled with a Z. So if somebody says FZ, it's right about there. CZ, PZ, right? Sometimes we can see spikes very close to the activity in that neighborhood. So that's basically how the previous lecture, for those of you who attended, they kind of talked about the technology of how they get the electrodes on. What I'm trying to give you is a sense of what we call the 10-20 system. The other term that neurologists often use, they say, I want to see it in a different montage. What do they mean by montage? It's very common epilepsy speak. Montage refers to how those electrodes are connected. Okay? So one common way we connect them is we go from, oops, sorry about that. Advanced service. Okay, there we go. Well, what you see here is they can connect the electrodes, this to this, this to this, this to this, this to this, in a chain, and then take the difference between those electrical potentials. Okay? That is usually called a bipolar montage, right? So the other type of connection is where instead of comparing this to this, this to this, this to this, you compare each one to A1 or A2. Those are the left and right earlobes, right? Why do we use the earlobes? That's because we think these are not electrically active. You can't sense brain activity here, right? So we're trying to get an absolute measure of what's going on in each place. So there are reasons why we may want to look at it in these different ways, depending on the circumstances. We don't need to go into the technical aspects of why we do this, but just know that when they're reading your EEG at the flick of a switch, they can change the connectivity to go differently. They can go from A1 to T3 to C3 to C7, CZ to C4, T4, A2, right? When they do this way, they call it a coronal montage. Why do they say coronal? It's like the crown, right? When we connect things this way and this way, to some people it looks like a banana. So you may hear sometimes a resident asking, are we looking at a double banana? What they mean is, are the two sides connected this way and this way, right? So those are just names for some montages, but the idea is always, if there is focal activity, we want to try to localize it. Of course, none of this applies in a generalized epilepsy, where activity may be in all electrodes, similar, okay? So, the other term people use when describing the EEG, this is important. That is, we sometimes say, oh, he's got some generalized slowing. So what do we mean by that, right? So we describe the waves in these different things. This is called a delta wave. Looks kind of like that. That is usually 1 to 3 hertz. Hertz being cycles per second. Then theta is a little bit faster, but it is still slow relative to what we call alpha. The alpha is usually 8 to 12. In a mature adolescent or a young adult, it should be right around 10 or 11. And it is best seen in the back of the head, right? If you're really relaxed, that's what you see. And interestingly, it's seen best if your eyes are closed, because we think of it as the idling rhythm of the thalamus and the cortex talking to each other, okay? And beta is kind of fast activity. Sometimes you'll get florid beta because somebody is on a benzodiazepine. If somebody got Ativan or Valium, if you come to the emergency room and we hook up the kid, and the kid got, let's say, a diastrat at home, you're going to see a lot of beta, right? Okay? So we commonly use these. The alpha that I show here is particularly important. We just run a resting thing. If you're in the ICU, we may see a lot of that. That's what we see in somebody who may be really neurologically suppressed, like a comatose state, right? Or a deep sleep, okay? So now, we want to point out to you that the background actually changes with age, right? The so-called alpha rhythm in the back that I told you, that's very important to us. That's how we judge slowing, etc. That's, in an average person, is around 10, 12 cycles, right? And then, so let me show you a chart here. So we say roughly the posterior dominant rhythm is age plus 4. So what we mean is, if you record a nice resting EEG in the back of the head, if you have a 2 or 4 month old baby, it's going to be 3 or 4 hertz. And we say not reactive, and I'll explain to that. See, by the time you get to 1 year, age plus 4, see, it gets to about 5-6 hertz. 3 years, it gets to about 8 hertz. By 15 years, it's at 10 hertz, and so on. Caps out at 10. But at the very young age, in little kids, you can say age plus 4. So this is just a chart showing how that posterior dominant rhythm increases quite a lot, steeply in the early years, and then kind of plateaus and goes here. And if you go way over there, if you have dementia, it'll start slowing, right? But this is what the healthy PDR looks like. Then we can also evaluate by EEG what sleep looks like. And right here, you're just seeing a normal awake one. You see a lot of things in the EEG that tells you why I tell parents when they're in the hospital. Many of you have been there for an overnight EEG. I'm always telling them, don't look at the monitor. You're here to look at your child and document, right? We don't need you to be looking at the monitor and giving me notes. Because the first thing is, the monitor is filled with artifacts, right? You don't know what the settings are on the monitor. We can make any wave look really huge or really low. It's just like the volume control on your radio, right? Similarly, we can really make things look clean by putting a filter, electronic. So the monitor is there just to make sure recordings are taking place. It's not for the parents or the family members to try to interpret, because every once in a while I come in the morning and I realize the parent didn't even document seizures that were going on. They never saw the baby. They were fixated on the monitor. And then they were marking all those things, because right here, see that? That looks really busy, doesn't it? That is complete crap. It's not serious stuff. See, brain activity doesn't look that sharp. What that is muscle activity. Right? You'll see eye blinks, you'll see chewing artifacts. So the hardest thing in reading an EEG is actually to know what is real and what's not. Okay? So this is a good example. You know, an experienced encephalographer would say, oh yeah, this pretty good awake recording. To them it looks really normal. To you it looks kind of noisy, not very clean, right? So but what they're trying to show you is even in this, we can pick up that alpha rhythm or the posterior dominant rhythm. So Dr. Hiroki put this box to show you that if you expand it, see, you can actually see that. See that? To count that in 1 second, that comes to about 11 or 12. So we have to pick up little moments, Now, what do we mean by reactive? What we mean by reactive is we get it best when they have their eyes closed. They need to be relaxed with their eyes closed. If they open their eye, it goes away. Why? Because remember I told you it's the idling rhythm. In the back part of the brain, when you open your eye, it's not idling anymore, it's looking at stuff. So immediately it'll speed up and it'll become flat, right? Because that's what the occipital lobe does. It gets visual information, it's not idling anymore. So that's why what we mean, the response of that rhythm to very quickly change, where an encephalographer can just look at it and say whether the eyes are open or closed. That's what we mean by reactive. When somebody is really, really, really sick, like in the ICU, it may not be reactive. The EEG is not reactive. Sometimes the EEG tech may even go and clap their hand or pinch a shin. And if it doesn't change at all, in a deep coma, you're really in trouble, basically. So the EEG should react. Okay? But this is a good demonstration of right here. See, E4O2. Remember I told you the banana type of connection? So this is the right side, parietal occipital, looking at the back of the brain. This is on the left side. Notice they give you a beautiful rhythm you can actually count. Okay? Now, if that thing, if you got it and the patient is awake, relaxed, let's say it doesn't give you 10 or 12, and it gives 7, and the patient is 20 years old, you're going to say they have some slowing by that time. Okay? So when you get drowsy, what happens is that posterior dominant rhythm naturally becomes a little slow. So it goes from that alpha range that I talked about to theta range, right? And that's what you see here. If you look in the back part of the head, it's probably difficult to see until we exaggerate it a little bit, right? And in stage 1, we also get these things that look like sharp spikes. They happen right in the midline. They're just called vertex waves. So if you don't know much about EEG, you'd say, oh, that looks like trouble. It's not trouble. That's just what happens when you get drowsy, right? And we usually look at it and say, that's stage 1 sleep. And if you do look at the back still, notice that alpha rhythm is no longer there. See, these waves are a little bit slower to move. Okay? Those are vertex waves. And here's a magnification of the vertex waves. You'll notice they're very prominent in the midline, right? All right, CZ, C4, CZ, CZ to C3. That's right along the midline. Okay? Then when you go to stage 2, you see further slowing. Notice in the back leads, see now, that's only about 4 waves, right? Instead of 10 or 12. So it's really beginning to show slow, but it tells you this is happening and they're falling asleep. They're not sick because you saw the vertex waves, right? You know that comes with early sleep. Okay? And then we see these things called K complexes, right? That are usually this whole business. And then in stage 3, you can see all you see is everything is slowed down. See, nothing looks like, right? There it is, right? So that is slow EEG, but it progressed from awake to drowsy stage 1. So if you see this, you don't really panic. Not only that, what would happen if you start talking to that person, or let's say you put your hand on the shoulder, the EEG will change because you'll get arousal, right? You lose the slow waves immediately. But if somebody's on a coma, that won't happen, right? So again, the magic word, the EEG is, it's reactive, right? That's what tells you the patient is okay. And then there are standard physiological patterns. You don't really have to know them, but your neurologist should know them if he's reading. And a lot of them don't, right? You generally don't know a lot about EEG. You're seeing a few epilepsy patients in between your Alzheimer's and Parkinson's and low back pain and carpal tunnel syndrome. That's epilepsy people just do epilepsy, right? Okay. So that's called a mu rhythm, that's normal. There are other, this is very funny. If you are a non-encephalographer, that looks like somewhere here he started a seizure and it went from here to there. Except that it isn't. It's called hypnagogic hypersynchrony. That means particularly young 10, 12-year-olds, when they get sleepy, they get these giant waves. There's a lot of synchronization. The neurons tend to fire synchronously, but it's not a seizure, right? It's a normal, acceptable pattern. Likewise, lambda waves that are kind of hard for you to see, those are those little things, right? That's normal. That's not a spike. Okay? There's a magnification. Posts are another things that we can see in people. Posterior slow waves are beautiful. They're not normal. Right? And then, earlier, there was some confusion. I don't think any of you were in the previous lecture. The EEG tech was trying to talk to patients, to the audience, about how a normal EEG requires a number of exercises during that spell. One of them is hyperventilation. They talked about deep breathing, and the very organic person sitting here confused it with the yoga or deep breathing exercises, which is really not what hyperventilation is. It's actually an exercise to bring out an abnormality. You're not calmly deep breathing. You're not doing mindful breathing. You're really breathing hard. With little kids, I usually use my finger and say, pretend, I do this in the clinic sometimes. Pretend this is a candle and you're trying to put it out, except it's not going out. So you're going to do it as deep and as fast as you can. Right? That's nothing like a yogi would do. You're doing this to blow off carbon dioxide. When you blow off a lot of carbon dioxide, right, it produces biochemical changes in your brain. And some people, normal people, would respond with slowing when that happens. So what you see here is instead of that alpha rhythm, notice, you've got sort of a theta delta. That's an okay change. But in some people, like a 7-year-old girl that the teacher thought was frequently just in a daze, is having staring spells. If you hyperventilate them, they may go into a spike wave seizure. I'll show you what it looks like in a bit. So you can bring out certain seizures with hyperventilation. But that doesn't mean it works for every type of epilepsy. The generalized spike waves particularly are responsive, okay, to them. So, and there are artifacts in the EEG, and here, I don't know how well you can see from the back. You see right here, this lead is showing little blips. Are they spikes? They're not. You know what's happening? See down here is the EKG. Notice it matches with the EKG. It's just picking up EKG unintentionally. Right? So the arrows in the top show the EEG lead, the bottom shows you on the EKG. It's very, very important to know how many artifacts you can get. Particularly if you're in the NICU or ICU, there is so much electrical stuff going on there, right? People used to say that's why you can stick a couple of electrodes in a bowl of jello and record beautiful waves. It's just not brain active, right? Okay? So here is just a magnification of the EKG and the T3A1 lead showing the EKG. Then you see these very, very sharp things. When you see super sharp things, they're never from the brain. There are two causes for very sharp things. This one here, shown in magnification. You see that rise time? How fast that wave goes up? That's never cerebral activity. Two things do that. One is electrode pop when it's isolated like that. Or like earlier you saw that really busy looking stuff, that's just EMG, muscle activity, right? So we talked a little bit about physiologic things like mu rhythms, vertex waves, spindles. We talked about the occipital background rhythm, right? And we talked about technologic hypersynchrony, delta waves or slow waves with hyperventilation. Now, let's look at a few abnormal EEGs, right? So, what about spikes? If you see a real spike. Spikes have a high association with seizures, but what an epileptologist does with spikes is not simple. There are times when I see a kid with a few spikes, I may not treat them. I may say, yes, we see this, there's a little bit of a risk for an occasional seizure, not very high, probably not worth the side effect of drugs, may grow out of it. But it takes experience to know what are those spikes that look like you would grow out of it, right? Other times, if you're a good history taker who knows the disease, the patient tells you a few things, and you run a quick and dirty 20-minute EEG, you pick up nothing. Does it mean they are clear? Not at all. See, they may have a deep focus, and you may not pick it up on the scalp unless it really explodes. When they're very quiet, it may not be picked up. So like in deep temporal lobe structures, you're not going to always pick it up. Sometimes we say, let's get an overnight EEG because maybe during sleep there's some synchronization, we may catch something, right? Or if we sleep deprive them, we may catch something in the morning. But sometimes, even without seeing the spike, I may say I'm going to start a medication because the story is very compelling that you have that type of epilepsy. Everything the kid is describing, or the adolescent is telling me, makes total sense. I already know exactly what type of epilepsy it is. The description is so good and convincing that we may say, doesn't matter, right now we don't see it on the EEG, but you have this. We need to treat you. So that's why, the bad practice is not to know the story of epilepsy and simply look at some artifacts and put people on medicine on a normal EEG basically, because you saw electrode pops or muscle activity and all those things. The other extreme is to be able to know when somebody should be on a medication, even though you don't have immediate EEG confirmation, but you can do things to increase the yield. Okay? So, here is a very interesting EEG. Remember I told you about the bananas, left side versus the right side. So here we have one side, front to back, the other side, front to back. Then remember we talked about the coronal montage? We go from one ear to the other. We go from this ear to the other ear. What do you see? Can anybody describe it? Does this look different than these two? Yes. It does, right? What does the tongue look like? The right side. Slow, right? It looks like slow. They're bigger, slower waves. So similarly, the whole right side here looks slower than the left side. So this patient actually had Stewart-Weber syndrome, and that's what they're showing, slowing confined to one side, right? Here in the coronal montage, as you go from this way, slowing is here, not over there, okay? And what happens in this case is, there's a good MRI. In the MRI, what I'm trying to show you is this side, this is the left side. Every time they show you MRI, they try to confuse you. What you see on the right side is actually the left side. Because you're looking at it as though I'm lying in the scanner on my back and my feet are towards you. So if it's on this side, that's my left side, right? So you see here, the left side looks okay, but you can see that the right side has a lot of atrophy. It looks funky, right? So that's Stewart-Weber. That person had one whole hemisphere affected. So corresponding to that, those leads are slowing. When you go this way, That part is this, over here is that. So that's a nice correspondence, right, of what you see. When you see the EEG, you know something is wrong with that hemisphere. You don't know it's towards Webber. This is why we need different modes of neurodiagnostics. Okay. So here we have another EEG, and this is, what do you notice here? Just simplest description is you see, it's fair to say, bursts of activity punctuated by suppression of the EEG. Funniest thing, that's exactly what we call it, burst suppression. And that is a very pathologic pattern in a very young baby. It's called the Otahara syndrome, named after my late good friend, Professor Shunsuke Otahara from Okayama, Japan. He first described this in newborns with totally horrible seizures. Typically, those who have this EEG, if they graduate to infantile spasms, another really bad pattern, right? Some of them die. The survivors go to spasms. If they survive that, they go to Lennox-Gastaut. There's no happy ending. We start with this. And now we are understanding a lot due to modern DNA technology and the genetics, right? Genetic mutations that predispose you to EEG. But again, it's looking at EEGs is very pattern recognition to some degree. Right? And this is what we call hypsarrhythmia. This is what babies with infantile spasms have. Important things are, you cannot see much by way of rhythm. It looks like the waves are really big, but a caution. See, if you don't know EEG, don't try to read it. Right? Because, seriously, what happens is a lot of times, I get young babies that do funny things, which may be benign, but then there's a suspicion. So we admit them for rule-out spasms. So the family comes very sensitized to this abnormality. This is called hypsarrhythmia. Hyps in Greek is mountains, right? It's mountainous slow waves, chaotic sharp waves. However, if you take a normal tracing of resting when things are not rhythmic but random, if you turn the volume way up, somebody could mistake it to look like, oh my God, those waves look really big, right? So you really don't want to ever try to interpret what's on the monitor, because you don't know what's being displayed, right? But this is ominous. This is infantile spasms and has specific treatment implications, right? This is another popular one. Many of you have heard one time or the other, Lennox-Gastaut. So you see there is spike waves that are kind of slow. What do we mean by slow? Spike waves that are faster than 3 hertz are okay. But under 3, they're 1.5 to 2.5. In that range, they are. And then when they have a tonic seizure, body stiffening, the EEG goes into a high frequency, low voltage pattern. Low voltage compared to these, right? And then it will go back to this. Okay? So, to an experienced sonographer, all you need is that one page and say, oh, that looks like Lennox-Gastaut. Right? And if EEGs ever look pretty to anybody, that would be this. This is what we call a particularly beautiful, generalized 3 hertz spike wave. Notice the spike waves are really, really regular. The frequency doesn't change. They come out of a normal background, they end with a normal background. Nothing what we call post-ictal slowing, right? Very crisp, on, off. And during that time, you can't talk to that youngster. That's an absence. Very easy to diagnose. This you can bring out by hyperventilation very nicely. We see that right in the clinic. And there may be one or two of you where I've had your youngster hyperventilate in the clinic. And here we have juvenile myoclonic epilepsy. Notice we have spike waves. It's maybe not obvious to you how are they different, but let me tell you, these don't look as pretty as that, and they're not as slow as that, right? The slow spike wave is Lennox sketched out. The beautiful spike wave is childhood absence, and the spike wave that is not so clean, we call it poly spike wave. Instead of like that, it goes like that. And it's not slow. It can be 5-6 hertz. That is juvenile myoclonic epilepsy. We can bring this out beautifully with a flashing light. Okay? Then, I mentioned to you earlier, bipolar versus referential montage. I'm not going to go into the niceties of it because it's a little technical. We try to sort of get a sense of the dipole of the field. Because if we compare everything to the ear, and if I have a disturbance here, the amplitude will be highest here when it's compared to the ear. But when I do bipolar, see, looking from here versus here, if it's in between, it'll flip sign, polarity, right? So we say there's phase reversal at C3. That means left side, central, I got a disturbance somewhere here, right? On the comparative montage, okay? These are central temporal spikes. Another common pattern you see in youngsters comes out during drowsiness. That's also why sometimes we don't like super quick EEGs and somebody never gets sleep. Right? They come out particularly during drowsiness. Okay? And they have a dipole, if you know what you're doing. And here we have a classic syndrome called aniotopos. These little spikes are all, you can see here, P402. And back here, in the P501. So they're coming, little spikes coming from the back. These are youngsters who have a very peculiar form of seizure. Their seizure involves vomiting. They usually have their eyes pinned to one side and they just vomit, vomit, vomit. It's like an autonomic seizure when the intestines are moving the opposite direction. It looks very dramatic on video, but it's a benign thing. A lot of them will get over it completely, and they're older. It's very treatable. But EEGs are very good sometimes. If you know, we try to match the story with the EEG. We don't just go with the EEG, right? And here we have Angelman syndrome. It's called notch delta, probably difficult to see in that mag, but here you can see delta waves are slow, but see here the little notches. We tend to see that it's just a morphologic niceness in somebody with autistic spectrum and seizures and no language. We see this and say, that looks like Angelman. How do we confirm it? We confirm it with genetic testing. Okay. Then, hope you're not too squeamish. EEGs can be done for diagnostics in a much more complicated way. When you won't just have 20 electrodes, you may have 80 to 100 electrodes all crowded in. Well, how does that happen? This is a patient of mine from Australia who was here just a couple of weeks ago. She had surgery that involved just one finger. She was seen by us 3-4 years ago. And at that time, we did a very, very limited resection. See here, the little, we took just the least amount of it because it seemed to be right in the motor area. Right? This is the right hemisphere, so left hand. So we did the least, and she was seizure-free for a few years. That did the job. But she started breaking through, and now she came because she was having almost daily seizures. The family lives in Perth, so they sent them right back to us because we are good at doing some elaborate things that I'm going to show you. So here, you can see we're beginning to put electrodes. These are called depth electrodes. They go deep, and they have several contacts along the way. So each one could have 4 to 6 contacts, sampling other than the surface. Then over here, you see the depth electrodes like this going down. Then you also see what we call grids. See, this is a 2x8, 2x8, 4x8. So you can see now, just in that little zone, there's a large number of electrodes, just in that little zone, right? And actually, I didn't even show you all, but they're described here. But the point is you can see how many electrodes there are. And they are going right on the brain surface or into the brain, so you can record with great precision. Why? Because the seizures are coming from the motor area, they're highly refractory. We want to know the relationship of the seizure focus to functional areas, right? So here you can see all the grids. We give them numbers, and then we try to carefully analyze it. But these are also used to do what we call functional mapping, right? We can see if they stop talking if we buzz an electrode. We buzz an electrode and the finger twitches, right? You can do all those things. And when you do those functional mappings, then we represent here, functional mapping showed that left-handed motor area is right around there. This purple is face motor area. The blue is what the PET saw. And we need to decide what the surgery is going to be. And then here's a very complex thing where we mark focal slowing, now that you know that language, right? We show focal things, then we show spikes. Notice sometimes the spikes are very far from where we think the action is, right? That's why just looking at spikes of the scalp is not enough for surgery. We see spikes. We again have that left-hand motor mark. This is the PET area. But see, here are actual seizures, the stars. So with all this, we have to come up with what do we need to take and what will be the deficit. Finally, we realized it goes so close to the face, there's going to be a little bit of facial weakness. The parents accepted the fact that it's on the right side. Little clumsiness on the left hand may not be that bad because she's already right-handed. Face, because our face gets bilateral representation, that weakness is most likely going to be transient. For instance, if you know me long enough and if you have met some of my hemispherectomy patients, right, they have weakness on one side, but their face is not funny. Face looks okay. So anyway, that case got done recently. I want to thank all my... It's a funny thing I got assigned to this lecture today, because I'm the only one in my group who actually doesn't read people EEGs. I have read a few rat and mouse EEGs in my time, but I'm more known for pharmacology, right? But we are still epilepsy people. But nevertheless, because it's not the topic, I wanted to thank Hiroki Nariai, the youngest and newest of my faculty members, to help me with some of those pictures. Let me tell you our team. We have a pretty substantial team. Arya, who is speaking in another room, is our surgeon. I think some of you know Sean. He runs the infantile spasms project. Jason runs the adolescent epilepsy clinic. Joyce Matsumoto runs the EEG lab and the keto. Hiroki is a very sharp investigator looking into high-frequency oscillations, which we didn't talk about. Raman is also speaking this afternoon. He's doing a specialized clinic for CDKL5 patients and things like that. And Lekha Matsumori Rao is the one who specializes on neonatal seizures and stuff. Joyce Wu runs my tuberous sclerosis center and clinic and all the clinical trials. Patty Walsh is our neuropsychologist. We have two nurses, Christina and Beth. So that's, unusually large number of epileptologists for a very small pediatric hospital. But we all have our little areas, but we work together as a team. And that's Hiroki in the city of Fukuoka last year. So I'll stop there and take any questions, comments. How are we doing with time? We got a little time. So feel free to ask me any questions you may have.
I have a general question. So my daughter had when she was treated, she was on medication, and then she was seizure-free for about 3 years. And then she went in for an EEG because you're not, and then the day after, she had her first seizure in 3 years. Are there studies, or can EEGs cause or induce or bring back after they've been dormant or paused for a while?
Well, the EEG is just recording what is there. But some of the types of genetic epilepsies, for instance, remember I mentioned the childhood absence, the beautiful piece.
That's what she started with.
Right. Those often overlap. Some people would have a complete remission. Others will go on to develop either grand mal or JME. We are still trying to look at all the genetics to see how to predict that. But we have always known that this is why we don't say you grow out of it 100%. We also say if you have absence under the age of 10, your likelihood of growing out of epilepsy altogether is pretty good. It's probably 7 out of 10, roughly, right? But if you start having absences around the age of 11 or 12, it's probably a lot smaller, right? If you are first diagnosed with JME, which has an interesting story, right? It's all these epilepsy syndromes are classic thing. It's not just the EEG. JME people often have myoclonus in the morning. Of course, you can't ask the patient, do you have morning myoclonus? It's not language we can use. You ask people, are you clumsy? Right? You have problem getting a toothpaste on the brush. You drop your oranges in the kitchen. Right? So people are very jumpy. But they don't know that's epilepsy. They can have short absences, but when they have their first grand mal, that's when we see them. But we ask about all these other things. But now some people can grow into one of these things after starting with childhood absence and having a period of remission.
So that's what she had, the childhood absence, the period of remission, and then she had the tonic-clonic, the grand mal.
Right.
And so then, are the chances then that she can still outgrow that? She's 16 now, or is it at that point now?
She may not outgrow, but in some people it becomes fairly easy to manage. She may be very responsive to the medication.
She's not. She's maxed out on Depakote and Keppra, so we're looking to look at options after that.
Yeah, okay. There are options. Yeah. Some can become challenging.
And they haven't done it yet, so they did like don't quote me, but like a 2-3 day over the weekend ambulatory. Do you recommend, or did you do a lot of like 5 days in the hospital under observation?
I don't always do that with this kind of syndrome.
For this one, okay.
Yeah, some people do, and I don't want to be criticizing others for what they do, But when people take somebody with primary generalized epilepsy, as we call it, something like what we can elicit with hyperventilation, right? And when you do 3 days, 5 days, I feel like you like the bitter. I'm sorry.
Because you already proved it.
Oh, because I can tell you, we don't do that ever. We never, there are many parents here of my patients who will tell you, I've never done more than one night, right? That's all we really need. It's not even 24 hours. I just need a good night's sleep in the morning, hyperventilation, fully. You already have the diagnosis. Doing it for 5 days doesn't help you choose a better drug, because you already have pegged what it is. So that's
very much.
Yeah. But an overnight can be very useful. But I think beyond one night, generally in my experience, that is, like that last page you saw, very complex localization. But this is not a localized epilepsy, so what are you going to see maybe for days?
So as the pharmacologist, at this point, the different medications would be the next step?
Yeah. And I try to educate and not give advice on patients I've never seen, because that's why I'm being a little restrained. Yeah.
Once for the initial EEG, how often should they be retested on it, or once they get that first diagnosis, it's just good?
Well, it depends, So when do we do a repeat EEG? Well, in some cases, happiest circumstances are you have somebody with Chandler absence. You put them on the first medication and the seizures go away. Sometimes you want to see a brief EEG every now. It's not overnight. That's one type of ventilation. You see, you really did catch it pretty well. So for that type of thing, we had a national study that showed even a 1 hour of video EEG will capture 85–90%. So there's absolutely no reason to do it for days. But we may want to see the response. Other situations, things look pretty good, but 2 years later, a patient may say, can I come off the drug? So the teaching is, if your EEG, if you can still force a few spike waves, even when you are on the med, you probably should force it. But if nothing happens, right? You went on the medicine at 7, you are 10 years old now, nobody has seen a seizure, then the teaching is if the EEG is normal, and I took her off the medication, chances are probably 2/3 that will be the end of the story. There's a 1/3 possibility you can come back later. So it's not perfect, but it gives you confidence. And if you still see the EEG to be a little abnormal, you can say, maybe we should treat.
Yeah, like my daughter's she has an outside. It's been a little over a year now, but it's only gotten from second fill medication. She's still having them. We haven't had the control of the Alzheimer's, and then she had her first convulsion seizure 2 weeks ago.
So that raises the other point, right? We often think a EEG is warranted if the seizures are evolving or changing. If people see something new that they haven't seen before. And then every once in a while, we pick up all kinds of things that we hadn't hoped to. But unless you do this, you don't quite know what's going on. Earlier in the EEG techs were giving a talk, somebody brought up a lot of issues with sleep apnea and some behavior confused with seizures. I remember years ago, one of my colleagues brought in a patient when I was on the inpatient service. I was not quite sure she was having seizures. My suspicion, I told the team when we were rounding, that I can almost guarantee you it's that VNS setting, right? But by having her overnight, we were able to prove that. What's happening as she goes to sleep, the VNS cycle is so fast. There's a branch of the vagus nerve that goes to the vocal cord. That's why people cough when you set it first. So it kind of tenses up, but if the off time is too short, it never fully relaxes. So you're giving, by your VNS setting, an artificial form of obstructive apnea. Then that is causing a change. And then, so it's very important to make that diagnosis, because what you need to do is fix the program, not add anything else. So we definitely, I think people are piling in who are probably not for me, but for the next speaker. So I'm going to disconnect my, okay? Thank you all for coming.